So first, thanks Sages for inviting me. I'm very happy and honored. I've been given the topic to defend and promote the ERCP in a meeting of surgeons. So please be good with me. I have nothing to disclose. So I wanted to put out why we're talking about ERCP and dealing with the cholecystectomy. Just 10% of American adults, this is a little bit of epidemiology, will develop symptomatic gallstones, of which 700,000 will need a cholecystectomy. 10 to 20% of this will have cholecystectomy. And cholecystectomy, as we know, is the leading cause of acute pancreatitis, which can result in 275,000 hospitalization annually, with a really high cost of more than $2 billion. So this is one of the reasons why the American Association of Gastroenterologists got together and put together guidelines for the rule of endoscopy for the cholecystectomy. And what they tried to answer, a couple of good questions, is what the optimal timing of the ERCP for cholecystectomy in patients undergoing cholecystectomy. What they found, a few things. First, when we compared the two steps, so ERCP before cholecystectomy versus the one-step laparoscopic cholecystectomy and laparoscopic common bile duct exploration, the stone clearance rate is 98 versus 88%. But there's longer hospitalization for patients undergoing ERCP. Another topic that they found very interesting is when you compare the two steps laparoscopic cholecystectomy with the intraoperative cholangiogram plus the ERCP if it's positive versus the one-step laparoscopic treatment, then the stone clearance is the same. There's no specific finding of longer hospital stays for the two steps, but in the laparoscopic group, 23% of patients will require ERCP. That's interesting. Another question that they're trying to ask is ERCP versus laparoscopic cholecystectomy? Because here we're talking about then all clearance the common bile duct. And all the studies that I will present to you are laparoscopic treatment of common bile duct exploration. And in this group, they found no difference in stone clearance, no difference in adverse events. Hospital stay was pretty much the same. But interesting, they found a 15% of leak rate in the cholecystectomy group, due to possibly inflamed ducts or small ducts. Those are risks in performing laparoscopic common bile duct exploration. Now let's talk a little bit how do we remove these stones. And let's focus on stones bigger than 10 millimeters, because those are the most dangerous one, probably they will give us problems. The Marvelous study looked at the difference in between endoscopic papillary large balloon dilatation without sphincterotomies versus endoscopic sphincterotomies. The 19 Japanese institutions involving 171 patients, they found the balloon dilatation group as significantly higher rates of single session complete stone removal and less frequent requirement of lithotripsy. In the subgroup of 67 patients that had stone bigger than 15 millimeters, still the large balloon dilatation was better than the sphincterotomy. And the lithotripsy also was lower. Adverse events were comparable. On the right side, this is my institution. This is courtesy of one of my gastroenterologists. This is a 3.5 centimeter stone removed endoscopically. That's impressive. Well, the topic that we're all looking for, ERCP versus laparoscopic common bile duct exploration. And the literature is, I think, has changed. When there was open cholecystectomy or open common bile duct exploration, ERCP won. But now, because of all the expertise that we have to perform minimally invasive common bile duct exploration, the literature now came back into prevailing the laparoscopic exploration, but not completely. So this study is for 11 randomized clinical trials involving 1,500 patients. They found the laparoscopic group has higher stone clearance, but there was no statistical significance. But statistically significant was the hospital stay that was shorter in the laparoscopic group. Mortality was the same. There is another interesting study, another meta-analysis, this one involving 13 studies and 1,700 cases. And again, the laparoscopic group had better results than the ERCP group. Significantly stone clearance and significantly lower comorbidities. But then, if we search the literature better and we go into more GI literature, this is a probably very interesting study. This is a 19 randomized clinical trial. This is almost 2,500 patients. It's a long period of time. And in this study, they found no difference in mortality, no difference in bile duct clearance failure rates, no different complication, and in hospital stay. So how is the RCP a better toy, a better tool for us for the cholecystectomy? This is the spyglass, and this article is very interesting just from Surgical Endoscopy 2021. And this is when we have a difficult biliary stones, defined as bigger than 2 centimeters, unusual shapes, difficult location. This study compared 78 patients in the spyglass group to 79 patients in the laparoscopic group. And I put the video of the spyglass because I was very impressed how we can have this advanced technology available. And this is what they found. By the way, on the right-hand side, again, it's one of our videos from our gastroenterologist. It looks like being on Star Trek. They blast the stone, and they're able to remove the stones, maybe not easily, but effectively. And this article that I was presenting to you shows how even if the overall stone removal is better, statistically better for the laparoscopic group, the stone remover in the first session is the same. The conversion rate to surgery, open or from ERCP to surgery, is the same, but the hospital stay is significantly shorter if we do this by ERCP. The complication group, the laparoscopic group, had almost double complication, including bile leak and residual stool. And residual stool is also very important. So with this study shows that for difficult stones, the spyglass guided laser lithotripsy is not inferior to the laparoscopic cone bile duct aspiration. Now, in conclusion, I think that the ERCP should be considered as a first-line therapy for cholecystectomy. Better evidence if the stone is more than 10 millimeter, less invasive and not inferior to the laparoscopic intervention, can be performed multiple times. The case-by-case basis and present on local expertise is probably the most important for decision-making. And at the end, I think more randomized clinical trial are needed for a final decision. Thank you.